recording. And as a reminder for everybody, we will have this up on YouTube afterwards that will be accessible. If I could ask Dr. Kasirye and Dr. Cohen, our fabulous panelists, to bring their video on so I can spotlight them for the community to see. Thank you. And Dr. Cohen. All right. Thank you, Dr. Cohen. Okay, so welcome to the COVID-19 community conversation, everybody. As a reminder, you can use the Q&A feature, which is at the bottom of your screen, in order to ask questions to Dr. Kasirye and Dr. Cohen around public health, around COVID-19, vaccines, anything that's on your mind. They are going to provide us a quick update on hot topics, like what's top of mind for them right now at the top of the agenda, and then we will get straight into your questions. You can also use the Q&A if you're having any technical difficulties, and we can respond to you through the Q&A there and try to support you in getting access to this conversation. All righty, well, let's take it over to Dr. Kasirye, and then we'll head over to Dr. Cohen to let us know about what's going on with COVID-19 in Sacramento County.
Yes, good evening, everyone, and thank you for joining us. So with the numbers, we are at 161,341 cases of COVID-19 reported to Sacramento County. We're averaging about 170 cases being reported per day, but that has been going up and down. But in the last week, it was trending downwards. And currently, our case rate is at 10.9 per 100,000. With the deaths, we're at 2,405. And we're averaging about 2 deaths being reported per day. We still have quite a number of cases that are still working. We're working through the process to verify the deaths. So there are some pending deaths that will be added as we get the verification. So 2 things I wanted to update you on. One is with booster doses. We are aware that a number of people have had some difficulty with accessing the booster doses, where they've gone to a healthcare provider and been told that they don't qualify, yet according to the guidance that has been provided that they actually do. So last week, the state health officer did issue a letter to the healthcare providers to remind them of the importance of being able to provide the booster doses, and especially giving priority to the groups of individuals at highest risk, those over the age of 65, those with underlying medical conditions that put them at risk, and also those that live in congregate settings, especially in places like long-term care facilities. The health officer also did say that because we do not have a shortage of vaccine at this time, that they should allow anybody who is interested in getting a booster dose to do so, so long as they are, if they received either Moderna or Pfizer, that there's been at least 6 months past the time that they got their first series, or if they got the Johnson & Johnson, that it's at least 2 months past their first dose, because it's really important for us to get as many people protected as possible, so that we are able to prevent a surge during this winter season. And recently also the CDC and FDA approved the use of the Pfizer vaccine for ages 5 to 11. And this is still under the emergency use authorization. So in public health, we have been able to add the new vaccine to the vaccines that we are offering at our public health clinics. The vaccine for children is different. Even the packaging is different. It's an orange top, just to help and make sure that no mistakes are made. And the dose is different. It's about 1/3 of the dose that adults get. We have been working with our healthcare providers within Sacramento County to make sure that pediatricians have the vaccine available, and also being able to support schools alongside the state to be able to have clinics at the school site. So this is ongoing. and will probably go on through the winter season. So with that, I'd like to turn it over to Dr. Cohen.
Having problems clicking today, sorry. Hi, I'm Stu Cohen. I'm one of the infectious disease docs over at UC Davis. And just a couple clinical comments I'd like to make as an introduction. One is that we are still seeing patients being hospitalized. We have sort of hit a little bit of a plateau. So we were on a plateau a couple of weeks ago. We started dropping a little bit, and now we're stuck on this next level. And the majority of patients in the hospital are still unvaccinated. Everybody in the ICU is unvaccinated. Everybody who's on the ventilator is unvaccinated. The few people who are vaccinated that are hospitalized are on general medicine wards. So the vaccine is still holding up as far as things go, but for our healthcare workers, we are seeing a significant number of our healthcare workers who are getting infected, and because over 90% of our healthcare workers are vaccinated, the large majority of people who are getting infected are vaccinated people, although they're not getting it at work. And most are not particularly sick, but it is still putting a little bit of a strain on the health system in general, because people have to be out of work, right? Even if they're not very sick, they're quarantined. And so depending on where it goes and in what units, it really still poses a significant risk, which is why we have still stuck with mask mandates within the healthcare facility, and even in person-to-person meetings where we know everybody's vaccinated. I think we just have this circumstance right now where we can't lose big chunks of healthcare workers who are not going to be able to be there, particularly given the concerns about potential surge in cases over the holiday season. So I think things are clearly much better than they were a year ago at this time. The vaccine has made a huge difference, but it still is, we still haven't totally gotten over the hill, I must say, and that's, I'm sure, frustrating to everybody in the population, right? Not just those of us working in healthcare. Everyone wants to get back to some semblance of where they were in January of 2020. Right, we're already, right, we all wondered whether 2021 would be better than 2020. Now we gotta hope that 2022 is a step up. And I will leave it at that point. I think that there'll be hopefully some questions to go through this in more detail. Well, one quick thing before I'm sorry. So I do think that there's a lot of positive stuff going on too. So besides the monoclonal antibodies, the protease inhibitor that Pfizer has developed is going to the FDA either this week or next week. And a week after that, Merck has a drug that blocks RNA synthesis called molnupiravir, and that's going to also go to the FDA. Those will allow us to do more things like we do with influenza, where we give people oseltamivir, or trade name Tamiflu, when people are are not very sick, and it keeps them from getting sicker. And it helps the disease get better faster. There are not a ton of side effects with these things. The Pfizer drug, there's going to be a lot of drug-drug interactions for older people who are on multiple medications. But these are advances forward, and they're moving us towards hopefully a time period where we can just say we're living with the idea that people are going to still get COVID, but it's not going to be like it is right now. Now I'll stop for real.
Thanks, Dr. Cohen. Well, there are some really great questions that are coming on the heels of a lot of the comments that both Dr. K and Dr. Cohen mentioned. So let's get started with some of those. So we have a question from Jeffrey. And Jeffrey, I know you had a couple questions in here, so feel free to pop in another one if I'm not representing this accurately. Jeffrey was wondering, sort of beyond the vaccine card, beyond schools, where else is testing required and where else is testing going on?
There are a lot of places now that are offering testing, including pharmacies, healthcare providers, and it's actually even being offered at the airport for people that are traveling for international travel. So where it is required in certain health settings, such as healthcare, and this is because of state health orders that were passed a couple of months ago. Healthcare and in jails and people who work in homeless shelters as well. It's also required for international travel. And some other activities also, like performing arts, they are doing testing for the individuals that are involved. And plus also many of them do verification of vaccination prior to events. So those are the main places. Apart from that, it is recommended for somebody who has symptoms that they get tested. Also, if you are notified of an exposure, you should get tested as well.
Great. And there's just a follow-up question here from Michelle around testing that I think ties in nicely. What type of testing is used to determine the COVID-19 positivity rate?
The positivity rate that we post on our dashboard is based on the PCR test. The antigen test is also reported, but it's in a different system, so it is not reflected in the numbers that you see on our dashboard.
Got it. And it seems like a lot of people make the claim that they know of people who have died from the COVID vaccine. How can we know what is the truth and what is just anecdotal in this matter of supposed vaccine deaths?
I think the most important thing, I'll start off and then I'll let Dr. Cohen speak as well. But I think the most important thing is to get your information from reliable sources, because sometimes people may think that they know somebody who died, and maybe the person did die sometime after they received the vaccine, but it might be due to something else that they had. For example, if somebody had diabetes or had a bad heart and they developed complications, not at all related to the vaccine, but it just happened that they developed those complications after the vaccine. People on the outside who are not privy to the details of the case might come to the conclusion that there is a connection. And I know many people have asked us about the VAERS database. And I want to repeat again that the VAERS database is an open database that was set up by the federal government to be able to allow for early detection of adverse outcomes. Anybody can report to the VAERS database, either the person who feels that they have had an adverse event, or the relatives or healthcare providers or the health department. I think what people need to realize is that that information is not verified, because people put in the reports, and it is those reports, at least a lot of the information from those reports is available to the public. But it's only when the federal government goes in, gets the information, goes to the medical records to verify the information, that they're able to verify whether there's a link or not. So it is hard to take the information that you see on the VAERS database and use it to make any conclusions about the safety of the vaccine.
Yeah, I guess I would just reemphasize what Dr. Kasirye just mentioned. I think that things get passed around now online, and you just have to know who's posting. Some of this stuff feels like there's a political agenda associated with the fact that they're posting things, and you can't really tell. And as has been stated before, if somebody dies around the time they get the vaccine, there will be a full investigation, going through all the records, going through everything that's available in order to determine whether that was the cause or not, whether it, or even whether it triggered the event that was the ultimate cause. And so it takes a lot of time and a lot of energy to do this correctly. And to my knowledge, there's not been any. And these people that have had temporal exposures to the vaccine around the time they have a heart attack or something else, you can't really make that association. I guess I will leave it at that. It's just, right, I think you gotta look at what the big database numbers look like. And, we've found side effects to the vaccine, right? The myocarditis stuff came out immediately after people had started seeing it, right? So it's not like anyone's really hiding the information. But once people looked into the myocarditis, besides the fact that it's pretty darn uncommon, it also is generally pretty mild, and people get better, and long-term heart disease hasn't been seen. So the analyses are being done. It's not like somebody's trying to sweep all this stuff under a rug.
Thank you both. All right, so we have a pretty specific question here from George, but I think, more generally, there may be others who are interested in this, which is, there is a 6-year-old girl, day 1 had pain, day 2 headache and fever, day 3 COVID positive, day 4 is asymptomatic, now feels great. When should she get her first jab? Is she considered immunized for 90 days after her disease? We're trying to go to Hawaii.
So at least from my perspective, and I think Dr. Kasirye can also address whether she's really considered immunized. But from my perspective, I like the waiting a little bit. And I sort of feel good about the 90 days. And I think there are 2 reasons. One is that I think the short interval between the 2 doses of the vaccine was designed because we knew there would be a booster effect after the 2nd dose. But because it's the middle of the pandemic, you try to keep it as short of a time window as you possibly can. And it turns out that at least with some vaccines, particularly with the Johnson & Johnson vaccine with the 2nd dose, being a little bit further apart actually gives you a better response after the second dose. And so I think waiting 90 days may decrease the reactivity of the vaccine so that, and at least anecdotally, I've sort of seen that, but I know there's no real data to support that, where you may get a little bit more of a reaction to the vaccine if you take it too quickly after being sick. But the other thing is that you may actually get a better antibody response by waiting a little bit longer. And the immunity will last at least 3 months. So unless the state of Hawaii doesn't consider that safe, I would wait the 90 days myself.
And I believe also that because we've had a number of people contact our office, I believe that for the state of Hawaii, you can get a letter from a healthcare provider that confirms that the person was sick and is recovered. That would be in lieu of doing the test, because we do know that some people, the test may remain positive for a while, even though they have recovered. So that's something that you can look into.
All righty, sounds like some things for them to consider. So we have kind of switching gears a little bit here, moving away from Hawaii and moving back to Sac County. Lisa is wondering both about the employees at Sac County as well as UC Davis. What percentage of Sac County employees are fully vaccinated? Does Sacramento County require all their employees to be fully vaccinated? If not, why not? And then similar with UC Davis, did I hear it correctly from Dr. Cohen that 90% of the employees at UCD are fully vaccinated? What about the other 10%? Why are they allowed to keep their jobs in healthcare?
So I can start. So for Sacramento County, the only certain sectors are required to get vaccinated, and that is in line with the state health officer orders. So people who are working in healthcare, or people who, because as a part of their job, have to go to a hospital emergency rooms. Also those that are working in the jail and also in the homeless shelters. At this point, we have not expanded it beyond that because we wanted to make sure that we were able to have enough resources to take care of the ones that would meet the health officer order. We, of course, are also waiting for the federal mandate. Once that gets through the courts, then, and also once Cal OSHA gives us some guidance, we'll be expanding it depending on what the regulations state.
So at UCD, yeah, we're about 93%, I think, a little over 90%. The University of California has a vaccine mandate for all healthcare workers at all 6 or 7 University of California hospitals across the state. But there are medical and religious exemptions that people are allowed to declare. They're all reviewed by the legal people for validity. And then at least at UC Davis, everybody who is not vaccinated has to be tested twice a week by PCR in order to maintain their jobs. So we anyone who does get an exemption has to be tested twice weekly.
I forgot to mention when I was giving my update is that I do not know the rate of vaccination for the sectors that are required to vaccinate right now, because those records are kept by human resources. And the only times that we would request to review those results is if there is an outbreak in a facility and we need to know who is vulnerable and who's not.
Alrighty. So what, if anything, is the health department able to do regarding school districts that are attempting to take local control in order to avoid the indoor mask requirements and probable upcoming vaccine requirements?
Well, those are state mandates, and schools do need have responsibility to follow the state mandates. They are under the jurisdiction of the Department of Education. So my thought is that the Department of Education will be handling those situations as well.
How do you know that our DNA does not alter my child's DNA in the future?
So these vaccines are actually recombinant RNA, not DNA. And the way it works is you have this messenger RNA. The messenger RNA is delivered into the cell, and then it makes the spike protein from COVID-19, which is then displayed on the cell that it's grown in to generate the immune response. And then once it is delivered, the spike protein, the RNA is degraded by the cell. So it is short-lived. It will not modify anybody's genetic material. It doesn't go backwards from RNA to DNA, and it doesn't last beyond doing what it's supposed to do, because that's how all of the RNA in our body works, right? We make RNA, if, you know, whether we're making muscle protein or whether we're making anything else, the DNA becomes RNA, and the RNA makes the codes for the protein, and then it is destroyed. So there is no way that happens.
Okay, that's good to know. Is there a timeline for full FDA approval for the 12+ age group?
I guess I'm not aware of it. I don't know whether you are, Dr. Kasirye.
No, I'm not aware of it. I think there's been some anticipation that it will occur sometime beginning of next year, but I don't have a timeline.
All righty, so there's a little bit of confusion around when to get a vaccine. So we have one community member that says, as a senior citizen, we were first told by the doctor if we had underlying conditions, we were not to get vaxxed. And then it was voiced that we should get vaxxed if we have had cancer, etc. So I think there's some clarification that they're hoping for.
I believe I gave clarification at the beginning. I don't think that there was ever any time that we put out information saying that people with underlying conditions could not get vaccinated, because actually that's one of the groups that is at highest risk, in addition to those that are 65 plus. So definitely those do need to get vaccinated. We do recommend for people who have had previous allergic reactions that they check with their healthcare provider first. But otherwise, for people over the age of 65, those in congregate settings and those with underlying conditions are considered among the highest risk and should get vaccinated, and should also be prioritized for the booster dose.
Yeah, I would agree with that. You know, sometimes things may get a little bit muddled, because if people are immunosuppressed, we want them to get vaccinated, but they may not get a good reaction to the vaccine, right? They may not develop a good immune response. And so sometimes maybe that gets confused into the idea that, well, if I'm not going to get a good immune response, why do I even get the vaccine in the first place? But the point would be that first of all, there's no guarantee that you won't get a good immune response. And you can't get a good immune response if you don't get vaccinated. And as Dr. Kasirye mentioned, that is the group of people that's the highest risk to get the most severe disease, and should be first in line.
All righty, well, we appreciate y'all's clarification of that. Let's switch gears to masks. We have Cheryl who has a question about Sacramento County order requiring masking indoors, more stringent than Cal OSHA. The root of the question seems to be, can you cite a definition on what is considered an indoor public setting?
Sure. So the reason that Sacramento County, along with a few other counties, issued masking mandates indoors is that, if you recall, in the summertime, when we first started seeing an increase in cases, the Sacramento region was actually an epicenter, and we were among the earliest counties that actually started seeing an increase in cases as the Delta variant was surging. So in looking at what was happening, and also the recognition that even people who were vaccinated were at risk of getting infected and could also pass it on to others, we, looking at that data and looking at how quickly the numbers were going up in Sacramento County, we decided to issue a mandate that was stronger than the language that was in Cal OSHA or the state recommendation. We have set a target of getting to 5 per 100,000 case rate to be able to actually end that mandate, in which case would revert back to the recommendation and the mandate that the state has put in place. The second part of the question was about what constitutes a indoor public space. There are a lot of places that can be put into that category. I think any place that you go that is not in your home, where you are mixing with people from other households, could be considered a public place, especially if you have a lot of people and crowding. I think those are places where you have the highest risk, and you should definitely wear a mask in those situations.
And we have another follow-up question about masks from another community member that's wondering, do we still need to wear the mask in the Sacramento region now, especially in a federal building?
Yes.
All righty. And one other item off of what you discussed, Dr. K, around the case rate, is there any consideration to change the case rate target of 5 to a higher number for relaxation of indoor mask mandates?
Well, at this time, we still feel that the case rate of 5 per 100,000 is a good target, because at that point we will have low enough numbers that the risk of infection is much lower. So we're still continuing to monitor, but right now we feel that that is a good target. If you recall, on June 15th, when the state opened up, Sacramento County, the rate was at about 5 per 100,000. So that's part of the thinking that went into selecting that target.
And does the booster change any sort of mask requirements? So essentially, if I get the booster, do I have to still wear a mask?
We are still keeping the target at looking at just the case rate. So even for people that have received the booster dose, of course, we know that the risk is much lower for people that have received the booster dose, but I think it is safer, especially when you're in a large crowd, to continue to wear a mask indoors.
Got it. Thank you. There is currently an epidemic of COVID in the jails. Can you tell us what measures are being taken? Will some of those who are incarcerated have early release as they did at the beginning of the pandemic?
So the early release, there was a blanket, permission to allow for early release earlier on in the pandemic. And so when we had the surge and the outbreak in the jails during the winter season, we were able to use that. This time around, that ended. And so we had to go back to the courts to request permission for early release. This time around, we did not get a blanket permission. So what the correctional health staff have been doing is that they create a list of individuals that are at highest risk, and they submit that to the courts, and the courts will review and make a decision as to whether that person can be released early or not. Other things that the correctional health staff, as well as the sheriff's deputies, are doing is making sure that the people that test positive are separated from those from others, and also checking for symptoms. And also when someone is first booked into the jail, they are also put in a different area and go through a period of quarantine and testing before they're allowed to go into and mix with the rest of the inmates in the jail. So those are some of the measures. The other is also that most recently the jail correctional health was able to get the monoclonal antibody. So that treatment will also be made available to especially people that are at highest risk.
All righty, thank you. There's quite a bit of interest in the difference between an at-home COVID test and one from a pharmacy or doctor's office. So folks are wondering, are the at-home tests accurate? How do they work? Are they being used at schools, jails, et cetera? And are they effective?
Go ahead, Olivia.
I'll let you start, and then I can add.
Okay, so there are just a couple of comments I was going to make. So first, there's a distinction. The home tests are antigen tests. Most of the tests that we use, at least in the hospital, are PCR tests. Antigen tests are generally less sensitive than PCR tests because there has to be more virus present because it's not amplified. PCR is a technique that sort of takes a needle in a haystack and makes it into a million needles. And so you can find them where the antigen tests don't have that kind of amplification. So they are intrinsically less sensitive. The home tests run around 85% sensitivity. There's a small number of false positives as well. And the home tests, at least some of the ones that are most popular, I believe the Binax Now test actually works like a pregnancy test where you look for a little line on a piece of paper that will determine whether you have COVID or not. And so depending on how dark the line is and how well you can see it and read it, that's where some of the false positivity and negativity come in. So even an antigen test done in the hands of somebody who's reviewed those tests before is going to be a little bit more accurate, but it's never going to reach the accuracy of a PCR test.
And just to add on to that, right now in the schools, and actually for many of the workplaces as well, they are also allowing the antigen test to be used. But the one that they're using is, the test is conducted by someone who is trained and it is under the jurisdiction of somebody who's licensed, like a lab director. The home test, there's no way of validating, and we have seen some where people are doing the home test wrong. So it's a little bit more variable in terms of the accuracy because of that, because the people who are using it are, it's just a regular test. As Dr. Cohen said, it's very similar to how a pregnancy test is done. So in some cases, if you do use a home test and it is positive, especially if you have symptoms, you will be required to get an additional test done. But of course, the advantage of the antigen test is that you get the results in a relatively short time. So it makes it much easier or helps with making decisions, especially in a school setting where you're having to make decisions as to whether somebody needs to go home or if you have to start a contact investigation. So both of them do have value, but I think with the home test, the concern is with the variability because there is no control, and the person who is doing the test may not be doing it accurately.
The one other comment that I would add to that is that, if an antigen test is positive, there's probably an awful lot of virus there. And those are going to be the people who are definitely most likely to transmit to somebody else. And so it serves that purpose as well. So maybe it's not as accurate, but the people who have lower amounts of virus are probably less likely to transmit. And somebody with a positive antigen test, has to be sent home.
All righty. So there were a bundle of questions about that. I think the only thing that wasn't responded to is we had one follow-up from Sandra who said, if a child has had their first COVID shot and a week later has a positive on their test, could it be a false positive?
No, not really. It's a different way, and the test doesn't. So there are 2 points. Most of the tests don't look for the spike protein, or they look for specific parts of the spike protein. There are usually different targets that they go after that don't change as much as the spike protein changes. So they're not going to be picked up by these tests. And there's also no viable virus made by the vaccine, so it won't be picked up by these tests. There are several reasons why they will not. It's not going to cause a positive test.
I also want to point out that when a child gets the vaccine, it's injected into the muscle, and that the mRNA stays in that area, and also the spike protein that is created also stays within that area. So whereas when you're doing the test, you're actually taking a specimen from the nose. So again, the vaccine does not result in a positive test.
Right, and a lot of the PCR tests, as I say, use targets different than the spike protein because the spike protein changes. And when the Delta variant became predominant, there were some PCR tests that couldn't pick it up because it had changed enough, and those were the ones that used the spike. The other ones used something else, and so that wouldn't even register with anybody, even if it could possibly cause something like that.
All righty, thank you. A lot of good things about testing, and in the chat, I put the Sacramento County COVID-19 testing webpage, which has a lot of resources, including our county testing sites, which do have antigen as well. I know that that's an interest for a lot of people. So we have some interest in boosters. Dr. K, we had somebody who joined a little late, was wondering if you could go over what you discussed at the beginning around boosters in terms of who really does need boosters. And then maybe we can talk a little bit about if folks can get a vaccine booster and flu at the same time, and a little bit about mixing and matching too.
And getting off of mute. So the first question about getting the flu vaccine at the same time as the COVID vaccine is a yes, you can do that. And in the public health clinics, we have actually been offering both. And many people have been taking advantage of that. Your other question was about boosters, and what I mentioned is that because initially the FDA and CDC put out some criteria as to who should get the booster, there was some confusion, and some people have called us and said that they tried to get an appointment and were turned away, even though according to the criteria we gave them, they actually met the criteria to get a booster dose. So last week, the state health officer issued a letter to the healthcare providers to tell them that basically anyone over the age of 8 who wants to get a booster dose should be able to get a booster dose. They can self-attest right now for their risk, but my understanding is soon that self-attestation that appears in the My Turn website actually will go away. And especially also, we know now that the FDA is considering recommending the Pfizer booster dose for everybody. So that will make things easier. For people that want to get the booster dose, it has to be at least 6 months from the first series that they got, if they got either Moderna or Pfizer. And if they got the Johnson & Johnson or Johnson, they should get, it should be at least 2 months. The other thing that I mentioned also is that for people who are at highest risk, those over the age of 65, those with underlying medical conditions, and those in congregate settings should be prioritized to get the booster dose.
And the last question there, just around mix and match. Maybe Dr. Cohen, you could, I saw you unmute, maybe you can address that with your other comments.
Yeah, all I was going to say is people have 2 arms so they can get 2 vaccines. And so, but as far as the mix and match, so the data that I saw that was presented to the ACIP, to the CDC's Vaccine Advisory Committee, looked to me like if you got Pfizer and you got Moderna as a booster, it didn't seem to make that much difference compared to getting another Pfizer dose. And the same with Moderna getting a Pfizer booster. It did seem to make a difference if you got the J&J vaccine. So if you got the J&J vaccine and your second dose was one of the 2 mRNA vaccines, the antibody response was higher than it was if you got another dose of the J&J. So I know people have been interested because there's some question as to whether maybe the antibodies last longer with the Moderna vaccine than they do with the Pfizer vaccine, and there are less breakthroughs, and the doses are different, and the composition of the mRNA is a little bit different. But the fact is that they're so darn similar that there's really not much of a reason to switch around, unless you walk into a drugstore or wherever you're going to get your booster dose and they say we only have Moderna today and you got Pfizer, then go ahead and take the Moderna vaccine. It's safe and it works and it'll be good. I am personally advising people who got the J&J to get it when they get their second dose, to get an mRNA vaccine.
Alrighty, thanks, Dr. Cohen. We have a community member that's concerned that we're passing over their questions. We go from in the order that questions are asked, and we are privileged to be getting a lot of community member participation. So we apologize if we're not getting to your questions soon enough, but I think we're about to get to one of yours. So that'll be great. So we have a question from Michelle about the CDC encourages laboratories to consider the adoption of a multiplex method that can facilitate detection and differentiation of SARS, COVID-2, and influenza viruses. When will this new testing begin?
So we do it already, actually. So our rapid COVID test is has COVID and influenza A and B in that testing methodology. We have standalone COVID tests because that's where we have most reagents, and a lot of the COVID screening that's done are people who are going to undergo surgical procedures and don't have symptoms and just need to be screened, or somebody who's going to be going to a skilled nursing facility, or somebody who's going to be going to a psychiatric facility where they all need to be tested before they go. We just use the standalone PCR test, but we like the idea of multiplex tests. If we have reagents, we do the combo test as our rapid test. And there are multiplex tests that test for a lot more respiratory pathogens than just influenza and SARS-CoV-2. Many of those tests have started to incorporate SARS-CoV-2 into it, but a lot of them have not. So if they're not already available, they're all rolling out, and a lot of places are already using the influenza COVID combination test already.
I do want to point out, because sometimes we have heard comments that, and people have misinterpreted what the CDC said to mean that the PCR test cannot distinguish between the flu and COVID. And I want to take the opportunity to clarify that, yes, the PCR test is very specific. It does distinguish between the two, but what we are talking about here is being able to test for the two viruses concurrently, because when somebody appears in a hospital, for example, and they're very sick, you want to be able to tell very quickly whether they have either one or the other, especially as we're going into this flu season. So there are a lot of advantages of being able to test for both of them concurrently.
Yeah, or potentially both, right? And so I think that's the other issue. And in particular, those are the most important ones, because those are the ones where we actually have treatment. So the other viruses on these respiratory panels will help you say that I know what this person has, but it may not necessarily make a difference as far as management, because we don't have specific drugs. But we do have specific drugs for flu, and we do have specific drugs for COVID-19. And so that's the other reason that these 3 virus multiplex assays are popular.
So pivoting back to masks and some other preventative measures, we have a community member that's concerned if Sacramento County does get to the 5 per 100,000 cases, but their specific town is still much higher in their local cases, that their local cases will spike even more. Are smaller towns considered in this within Sac County? So like if a small town has a larger case count, but Sacramento County comes down to 5 per 100,000, what does that mean for smaller cities?
We're just looking at the overall case count. If after we get to that, we have an area that has continues to have a higher case rate, we will, of course, continue to work very closely in that area to provide services such as vaccination and testing to try and get the numbers down. But what we're looking at for ending the masking mandate will be the overall number for the county.
Got it. There's another community member that often goes to a gym in Carmichael, and only about a third of the people there are wearing masks. What is the current requirement?
For people who are visiting gyms, they are required to continue wearing their masks even as they are exercising, but it is dependent on the owners or the business owners to enforce. And we are aware that some are doing a better job than others.
How important is physical distancing at this time?
Right now, we are not emphasizing the physical distancing. It was very important for us to have the physical distancing along with the masking prior to us getting the vaccine. But we know that the vaccines are very effective, and that actually is what has allowed us to not emphasize the physical distancing. Part of the problem with the physical distancing, as you know, is that it limited the number of people that could be in a certain area, for example, in restaurants or some of the other businesses. And so that was for many of them, it was very difficult to continue operating. So with the masking and the vaccination, that is our best protection right now.
All righty. Are there any plans to possibly update or find other means to have a vaccination card? There's concerns about digital identity and something maybe that could prevent the fake vaccine cards.
Right now, those are the options that we have: the vaccination card, and then also being able to get a digital version of it. The digital one is much better because it's much more difficult for someone to get a fake digital vaccination verification. But with the CDC card, we have to make it available because not everybody has access to the digital system. But of course, there are times where people have bought cards or used fake cards and gotten caught because they make mistakes, such as somebody writing down Madonna instead of Moderna. I think that's an easy way of catching if somebody is actually not. It's the same as the way that we verify for a driver's license. We expect that most people will follow the rules and that they will use the appropriate identification.
Alrighty. If people who have been vaccinated can still get and transmit COVID, why are they not being required to test at their work site?
So I can answer that to a degree. So people can get COVID. I think that they're much less likely to transmit if they've been vaccinated, even though the amount of virus in the nose is still pretty high, at least for part of the time. It seems to come down much faster, and the time period in which somebody can actually transmit to another person is very, very short. And when we looked at UC Davis for any potential transmissions in our healthcare workers, we haven't seen a single transmission in healthcare workers since April, and we've had vaccinated people get infected. Also, if people have symptoms, they shouldn't be coming to work. In a perfect world, might it make sense to get asymptomatic testing on vaccinated people? I think probably it does make sense. Is it the most cost-effective way to do it when you're already requiring everyone to wear masks and to do a symptom score every day they come in? I think it probably doesn't pay in a healthcare setting. And the capacity is not necessarily there to test multiple thousands of employees weekly as well. So just to summarize, can transmit, low risk though, and the other non-pharmacologic strategies will also prevent significant transmission. So routine testing, although it will add an extra bit of information, is probably not necessary.
Okay. All right. So George is wondering if we have data about long-term outcomes around immunizations for children.
We obviously don't, because the vaccines have just been rolled out. I think, right, we have now data on adults for just about a year, right? Because so the clinical trials were done in July and August. So maybe for the people in clinical trials, we have almost 18 months now. But for the people who got vaccinated in the first wave, that was December. And so we don't even have a year on adults, and kids, particularly the 5 to 11-year-olds, were vaccinated afterwards. And so we have no long-term data. Again, my take, and I will be interested to hear what Dr. Kasirye says, my take is that with most vaccines, the adverse events that we see are early, and that expecting something to happen 6 months or a year from now in somebody who didn't already have a problem early on seems to be very, very remote and very unlikely.
I agree with that assessment.
All righty. Is there a way to tell if I had COVID in February of 2019?
I'm sorry, is there a way to do it?
To tell if I had COVID in February of 2019.
Yeah, we can do it. Whether you actually, right? I will predict that you did not, but there is a test that we can do, an antibody test that will distinguish between somebody who got natural infection and somebody who's been vaccinated. If the antibodies have gone away because it's now over 2 years since your illness, I think that that could be a false negative test, but we can distinguish between antibodies that were picked up with natural disease versus those that were picked up by getting vaccinated.
What are emergency room staff told to do when an individual presents with a COVID-19 vaccine injury? Who is responsible for payment of those medical expenses after this happens?
So I will just say that most healthcare settings have ways in which we report serious adverse events with anything, whether it's a vaccine or a drug or something else, particularly if it's an unexpected one. There's a way to report this to the FDA through our pharmacy group. And so Now, I don't know whether emergency room personnel are told to do that because I don't work in an emergency room. But I think that there are reporting systems that if a healthcare person identifies something that they think may be related to any kind of medication, whether it's a vaccine or a drug or something else, it's reported to the FDA and presumably they will investigate. As far as the costs, I think that's probably on you.
So actually the VAERS system is one of the systems that can be used by people in the emergency room. But there are other systems as well, as Dr. Cohen mentioned, that are used by healthcare systems. As far as if someone has concern about vaccine-related injury, there are places where they can report it. I do not have it on hand right now, but we can definitely provide that information as to where people can go if they feel that they want to make a claim. I don't know how long it takes and what process it goes through to get to find, and I don't know of anybody who's gotten a reimbursement, but I know that those systems do exist.
And building off of that, Dr. K, I know you mentioned VAERS. There is a question about if VAERS is not reliable, then who is collecting and analyzing the safety data after vaccination?
So I want to clarify again, what I said about VAERS is that there's a lot of information that is collected in there. What I said is that it is not verified that the information or the reports that are in there are all related to vaccine. As we mentioned, if somebody thinks or suspects, they can submit a report. But what happens on the other end is that the FDA and CDC are looking at that information and they will pull data. They will go and request records to verify if that is related to the vaccine. For example, we mentioned that there were reports of the myocarditis. The way that those were picked up, one of the ways that it was picked up was through systems like the VAERS. And then, but again, it had to go through the verification process. The other is that, you know, I've lost my train of thought. Well, one of them is mainly, as I mentioned, through the looking at the information that comes through the VAERS system. And so, but again, it does have to be verified. Oh, the other thing that I was going to mention is also, if you recall, there was an issue about people getting blood clots after they had gotten the Johnson & Johnson. And again, that information was picked up by systems like the VAERS. But again, the experts at CDC and FDA had to then collect the additional information and verify that this actually could be related. You're muted.
Thank you. So we'll take a couple more questions, and I'm also going to put in the chat, if for some reason you don't get your question answered, how you can reach out to Sacramento County Public Health. But we do have a couple more minutes. So my daughter had 3 COVID tests through her doctor within 4 days. She had no fever, but did have a headache, runny nose, and cough. After those 3 COVID tests, each resulting negative, her doctor told her she had COVID, even with those 3 negative results. Why?
I don't know. Right, I don't think she had COVID. But I have no idea why someone would say that.
All righty. Would you suggest starting with a particular vaccine and then getting a second different type of vaccine to build more robust immunity?
Yeah, so I think we discussed that a little bit earlier. At least the data I've seen doesn't suggest that. It seems to me that if you want to get a different vaccine for your second dose or for your booster dose, that's perfectly reasonable because it looks like they work. But I don't think there's any real significant advantage, again, unless your first dose is a Johnson & Johnson vaccine. And then you do get a benefit from getting a second dose that's an mRNA vaccine.
What is happening on the COVID treatment front? Is anything proving effective? And what about the new therapeutic pills that have been in the news?
Yeah, so those are both, right, there are two of them. They work in slightly different ways, but they both prevent the coronavirus from multiplying in cells. One of them is probably going to require either, if it hasn't been put together as a combination pill, it will require a second pill that will serve to boost the amount of drug that's in the bloodstream. They both look like, if you have somebody who has mild to moderate disease as an outpatient and you give them the drugs, they will prevent people from getting sicker and ending up needing to be hospitalized between 50, 60, or 90%, depending on the studies that you look at. So these are very similar to the kinds of information that we've been getting with the monoclonal antibodies already, but somebody doesn't have to get an IV put in. They don't have to go to an infusion center. They can go to their doctor or other provider's office and get a prescription for medication, just like you would get penicillin if you had strep throat, or just like you would get oseltamivir if you had influenza. So I think they're definitely right. This is the way to live, that we're going to be living with COVID. Right now, we have outpatient therapeutics that make sense and that seem, at least in the clinical trials, to be well tolerated. We'll see what the FDA has to say next week.
All righty. So Dr. Cohen is the best. Just reading from the comments here. I've listened on many of your talks and his comments are thoughtful and honest. Thank you, Lisa. We appreciate you joining. So I'm going to put the Eventbrite link in here. So if you haven't yet signed up on Eventbrite, please do so. So that way we can contact you about future forums. You know, it's been confusing between the different Zoom ending and all that good stuff, but we want to have consistent communication. So we appreciate you sticking with us. Let's go ahead and hear from Dr. Cohen and Dr. Kasirye before we close out our time together. Dr. Cohen, do you want to start us off and Dr. K end us out?
Yeah, I will just say first, I thank whoever likes me. It's always good. But I will also say that I really appreciate these forums because the questions are thoughtful, and I think any way that we can provide education to the general population and make people more comfortable with what's going on. We're all exhausted. I understand that because I'm exhausted. But I think that we're really making progress and we're moving forward. And I think these forums offer an opportunity to give people some insight and some hope that we're moving in the right direction. And so I really appreciate everyone who shows up. I really appreciate the questions. And I thank you all, and I'll stop.
I also want to thank you for spending the time with us. And our hope always is that this continues to be helpful for you and that we are answering the questions that you have. And, I guess, again, to remind you that please get vaccinated. It's not too late. We are getting into the winter season and also holiday season with a lot of people, family gathering. So we're hoping that we can make this as safe as possible and prevent another surge during the winter. So I know everybody is tired already. We've been at this for quite a while, but I think there is a light at the end of the tunnel. We have 3 vaccines that work very well. And now we do have therapeutics that are coming up that are easier and easier to use. Some of them injectable, but hopefully soon we will have them in pill form also that will really make it easier for us to start looking at transitioning. I can't give you a date as to when that transition is going to occur to just having COVID as an endemic disease, but we know that it will come at some point. But right now, all of the efforts that we're putting into place are to try and minimize the number of people who die from COVID and also minimize the number of people who will have to suffer, as it can have very severe consequences for certain people. So we appreciate your patience, and we're hoping that as we get through this, that our numbers will continue to go down and we can end some of the mandates that we have. So thank you.
All right, thank you all, and much appreciation to our outstanding interpreters. Everybody have a wonderful night.